I think this one is probably for Dr. Cruikshank. And the question here is, Dr. Cruikshank, if someone is treated with the 3 weeks antibiotics as per the NICE guidelines, would you expect or want all the symptoms, e.g. the myalgia, arthralgia, fatigue, headache, to resolve fully? But if the symptoms are significantly improved, but remain to a lesser extent, would you prescribe another course of antibiotics at that point?
Okay, so personally I would. There are certainly cases where people describe that their symptoms improved. They came off the 3 weeks and they continued to improve, and that may well happen in many cases. But the guideline allows for you to retreat. And so my advice would always be to review the patient or tell them to come back unless they're completely well, which also includes the rash itself going. And the guideline allows you to give another 3 weeks of antibiotics. And so I would discuss with the patient and I would do that. Now, sometimes patients don't want more antibiotics. They're concerned about the amount they've already had at such high dose. So obviously you've got to discuss it with them, but my feeling would be to treat.
Yeah, thank you for that. Jack, do you want to add anything to that, or would you concur with that?
No, I'm fine with that. I mean, I think you treat patients. I mean, I believe in antimicrobial stewardship. So I don't treat half the patients that come to the hospital with viral illnesses to my acute care hospital. I stop the antibiotics all the time. But if you have somebody with a potentially life-threatening, or life-changing consequences of untreated or partially treated Lyme disease, a longer course of antibiotics that you commonly prescribe, for example, for acne for 6 to 12 months, doxycycline, limecycline, I just think that's a different game as far as that goes. So I think we treat the patients, and if patients improve in the antibiotics and continue to improve in the antibiotics, I think you should treat patients, not guidelines.
Okay, thank you, Jack. Thank you for that. Now, both of you, I think, when you spoke, mentioned that patients were often denied the test for Lyme, either because they had a diagnosis or because people felt that it wouldn't be helpful. We have a question here: that are the Lyme disease tests expensive? Is that why they're refused quite often, or is there another reason for it?
Well, actually, see, people go to Germany to get the test done in private laboratories, and they are expensive, and that really is a challenge. That really is a challenge. I mean, people will spend 1,000, 1,500 euros for tests to be done. So they are quite expensive, but the party line is we don't trust the German tests. Everybody has a positive times. The German tests are not accredited. They're not, they're not validated, et cetera, et cetera. So I just think we outsource infectious disease antibody tests for every other disease to in the NHS, in the Irish system, to private laboratories. There's a huge opinion that sometimes is unfounded that the private tests done for Lyme are not accurate, and the only tests that are accurate are the UK or Irish tests, which actually at best are 50% sensitive. They're not 100% accurate. Antibody tests are not 100% accurate. So I do think private tests are helpful to me, but Lyme is a clinical diagnosis. The testing gives you more comfort, and whether it's an Irish test or a UK test or a German test, it does give you more comfort, in my opinion. But I'm treating people because I have a clinical suspicion, and my assessment of people ask me all the time, do I have Lyme disease on day one? I say, I think so. Ask me in 2 months if you respond to treatment. This is the proof of the pudding is there an ongoing infection? If you respond to the antibiotics, there's a bacteria in there, and the most common bacteria is Lyme and sometimes the other co-infections. So I'm not answering your question 100%, but none of the testing is perfect. Until we have PCR antigen tests, we're going to have to use our clinical judgment to make decisions about treating patients.
Yeah,
I think I would say if the question is to do with in primary care, when people are asking for a test, I think there's a couple of issues. If it's very early, if someone had a tick bite yesterday and then they come in and want a test, then obviously there wouldn't be any logic in doing that. It's not going to be, that would be inappropriate, because there's no likelihood that they'd be infected if they've just had a bite. or no likelihood of a test being positive at that rate. I think the other question is something to do with not encouraging people. It's a bit like other tests used to be refused in the past, I feel like PSA tests. Let's not encourage people. Let's just reassure them and tell them it's fine. And of course, the other argument is that if you had a test that came back positive, it doesn't mean that you've got Lyme disease now. You may have had it in the past. You may or may not be symptomatic, may not be the cause of your symptoms. But I do come across a lot of people where they've literally been refused a test, mothers who've had to fight to get a test in children. And it's quite simple. It's on the normalized system. It's just, you just ask for Borrelia or ELISA. They'll do the first part. If there's any query, they'll send it on to Porton Down, and that will be more expensive. I don't know what the first test costs, but I don't see, compared to everything else we do, that there's an issue in doing that.
Thank you very much. There's a related question here, which I think is trying to help a colleague think about their own practice, and that should a Lyme disease test be included as standard for people with vague symptoms, where you suspect that there might be inflammatory connective tissue, fibromyalgia. And so the question here is, should they do a Lyme test as a standard there, or is there, and Jack goes on about it's a clinical diagnosis, is there more things, what are the triggers there to make the colleague there request a test?
Right. Well, I guess my opinion is, if you've got an isolated Bell's palsy, it probably is it's a Bell's palsy, you know. If you've got a Bell's palsy with multi-system involvement, tachycardia, migratory pains, you know, migraine headaches, other symptoms, that's a red flag. That's multi-system disease. Lyme is a bacteria that disseminates through your bloodstream and goes to multiple different organs. An isolated Bell's palsy from VZV, zoster, just causes localized pain in the face, or maybe cause weakness in the face. So I just think that, you know, that no, I wouldn't do a Lyme test in everybody with fibromyalgia. I wouldn't do a Lyme test in everybody with chronic fatigue syndrome. I think that's taken a bit far. But I just think that if you take a history, you know, if you're from the outer islands of the Hebrides, where, you know, where Borrelia is, you know, on one of the islands in the Outer Hebrides, there's, you know, 250 of 900 people are positive for Borrelia, and there's ticks all over the place, and deer all over, and geese all over the place. In that GP practice, I'd probably test everybody for Lyme disease if they had chronic fatigue syndrome. But I think you should try to individualize your evaluation. Use a history, use a physical examination, and then do an assessment. And Lyme testing should be much more readily available rather than denied.
Yeah, thank you, Jack. Dr. Cruikshank, anything to add to that, or is that?
No, I would agree with Jack. The one thing I say, sometimes you've got to be very careful. If you feel that maybe there's a psychological basis, you don't want to give a patient maybe an extra thing to worry about, to latch on to. Maybe this is Lyme disease and no one's diagnosed it. When sometimes I'd be very careful in how I would, you know, ask the question, maybe ask about history of rashes, history of bites, without specifically mentioning ticks or Lyme disease within the history. Just being cautious in some cases.
Yeah, thank you very much. We have a fairly straightforward question here, Jack. It's, can I clarify that an IgG positive is a sign of an older infection, please?
Well, I mean, you learn this in immunology. There's a window period where you have an infection in your body and none of the antibody tests are positive, and Anne talked about that already. So there's a window period, and the window period for Lyme can be quite long. It can be, I've seen people positive within 4 weeks, but I've actually seen people not go Lyme positive for 6 to 12 months after the original, you know, bullseye rash, joint pain, negative, and the GP refused to give treatment based on a bullseye rash. They kept on doing the test, and they finally crawled in a wheelchair a year later, and the test was positive. But the IgM goes positive first, but sometimes the IgM doesn't go positive, and then the IgG goes positive after that. The IgM then disappears, and the IgG persists, but it's not been well characterized. Let's use another example, syphilis. When you have syphilis, I've seen IgMs from syphilis stay positive for 3 years. Classically, you're told the IgMs disappear after 3 to 6 months. Lyme IgMs sometimes persist for years and years, and then you don't even develop an IgG response. So I think the thing is we're not, the classic teaching that IgM comes first, IgG comes later. It doesn't mean there's not an infection there. It's a red flag that they've developed an antibody response to Borrelia. And if you hear hoofbeats, think horses, not zebras. Very simply, if you have patients with multisystem disease that sound like Lyme disease, and then you've got either an IgG or an IgM or both positive, or even if it's negative in the right clinical history, Lyme disease is up in my radar screen.
Thank you, Jack. Thank you. This one's directly for Jack. It's a colleague looking for clarification, Jack, as to what combination treatment did you give cases 2 and 3? Can you explain how you approached the treatment?
Right. Well, the thing is there's no guidance for treating chronic Lyme disease, because if you look at the medical literature, it says it doesn't exist. You treat with 3 weeks of doxycycline. If you're not better, 3 weeks of amoxicillin, and then Bob's your uncle, you're better. I've actually based my treatments, based on the ILADS guidelines in America, which treat people for longer periods of time until they get better. And if you've got an infection for 2 or 3 years, I think it's different than treating an infection that you've had for 2 or 3 weeks. So if you look at Q fever, which is another infection, you catch it early, 4 weeks of doxycycline, you're cured. If you don't diagnose Q fever till 6, 12 months, you need a combination of doxycycline plus rifampicin, plus hydroxychloroquine for 18 months to cure infections. If you treat people with a chlamydia arthritis, you need to treat a combination. If you look at the clinical studies, you need to treat not 2 months of doxycycline, you need 6 months of doxycycline plus rifampicin. So I tend to use rifampicin, and I don't recommend all GPs do that. I'm just saying is that I see complex cases where doxycycline in itself is not going to do the job because the infection is too far along, the infection is deep in the tissues. So in the case where I had a patient with both Lyme and anaplasmosis, my treatment was cefuroxime, which has really good penetration and I use high dose cefuroxime, 1000 BD if they can tolerate it, and rifampicin and Lyme cycline, a tetracycline, and that is covering both Lyme disease and anaplasma. And I treat initially for a period of 2 months and try to get people off antibiotics as soon as possible. But if they continue to improve on the antibiotics, my experience is if you stop the antibiotics, they go backwards. So they get relapsed. So you haven't cured the infection. So I individualize treatment. But for example, the cases I've described, I use combination antibiotics that penetrate well into the tissues. And rifampicin is an antibiotic that gets into the cells, intracellular, works synergistically with the other treatments. And I think that's a better treatment for patients with longer standing tick-borne infections.
Thank you for that, Jack. There's a question here. The questioner hasn't mentioned do we know whether some people who spontaneously recover, now they haven't said whether that's post-treatment or not, and what the difference is between them and those that don't. So maybe we can take it as both those that are treated and those that are non-treated. Are there people who spontaneously recover from
well, the issue is how do you know they spontaneously recover? I mean, Lyme is a low-grade pathogen. Syphilis is a low-grade pathogen. They're both spirochetes. There's other leptospirosis is a low-grade pathogen. I've seen patients not treated for leptospirosis. I've seen patients not treated for syphilis. I've not seen patients not treated for Borrelia. And what happens is they control the infection. The infection doesn't miraculously disappear. The infection goes into the cells, the infection disseminates and goes into different organs, and at certain time periods, it reactivates. So you become pregnant, your syphilis reactivates, you become pregnant, your Lyme reactivates, So I don't think that it just spontaneously disappears. I just think that your immune system controls it, and following another insult or damage to your immune system, it can reactivate. It happens with syphilis. It's well described with Lyme disease. So I think this myth that you know, I guess if that's the question, if you don't treat Lyme disease, it doesn't disappear miraculously. It may just go dormant for a period of time, but I think it does reactivate down the way, and it does need treatment at some time point.
I suppose I would say they've done some surveys, haven't they, on forestry workers in some areas of Europe, where they've shown a lot of people have tested positive for Lyme, but never actually been ill, or apparently ill. But then, as Jack says, it's difficult to know whether there are any long-term issues in that. But certainly there are people who've been tested positive with never having any apparent problem.
Yeah. And probably, like you said, that maybe they get treated with antibiotics for other things, you know, and maybe those antibiotics are curing the Lyme disease as well. We don't, since we don't have good PCR antigen tests, I mean, there's huge room for research and better understanding the natural history of Lyme disease. We don't have all the answers. I'm just kind of giving you, they've done extensive studies on syphilis, and that's the best analogy I can give you. Syphilis doesn't spontaneously go away. You can get syphilis when you're 18, the ulcer disappears, and then you become 60, and it goes to your brain because you have immune senescence. It goes to your brain because you develop HIV, you know, and you get neurosyphilis from an episode of you know, 40 years before. So it doesn't spontaneously disappear without treatment.
Yeah. Okay, thank you so much. Can I just ask any final questions to Dr. Hussain, please? We are coming up to the formal time when the session closes at 15:15, but the speakers have indicated that they will go on to 15 minutes later if we have some questions. Can I just remind everybody, please, to complete their course evaluation form? It's really important to us that we get feedback so that we can plan the next sessions. So if you could please, if you are planning to leave at 8:15, if you would complete that form before you leave, or just after you leave, that would be really helpful. I'm just going to ask Gordana if there's any other admin issues that I have missed, Gordana, before we complete this part of the session.
Thank you very much. There are a couple of things. So I have inserted a link to the feedback in the chat. So if you click on the link, you will arrive at a feedback survey. It will only take you 2 minutes to complete. And this is really useful for us because it will go back to the course directors anonymized. So we won't know who has said what. And they will be able to design future courses based on your answers. The other thing is, if you are planning to ask for a certificate of attendance, the certificates of attendance are issued by Tina McHugh. You can find her in the chat, in the list of panelists. And she won't be able to issue a certificate of attendance if your name is not on your device. So if you only have a first name or if you're called My iPad, we won't be able to issue a certificate of attendance. So if you haven't changed your name and you want a certificate of attendance, please do it now. And then a final thing, we will send links to the recordings for all 3 sessions after tonight to the people who have booked on the event, including those who couldn't attend. The links will remain open for a period of about a month. So that's it. Thank you very much.
Thank you very much, Gordana. Thank you. With 1 or 2 other questions for those that are leaving us now. Can I just thank you for coming tonight? Very much enjoyed your participation, and I hope you enjoyed the sessions, and we look forward to seeing you at future sessions. Please share the links that we'll send you for the live recordings with any colleagues who you think might benefit from it. And thank you very much for your attendance. Thank you. Jack and Anne, there's just a couple of questions here that remain. The first one I think is more for in Anne's field. In primary care, Anne, are there key or common neurosymptoms associated with Lyme disease to look out for? Where this is where a patient becomes unwell, but you don't really understand what the cause is for that. What would trigger you feeling that maybe to look for Lyme disease in particular? What kind of symptoms?
Obviously, the facial palsy that we've discussed previously.
Yeah.
Maybe just atypical things, things that you wouldn't expect people to imagine or make up. Gareth discussed last week how Millie had fasciculations that were visible in her arm. Or it may be that there are combinations of symptoms. Sometimes people have odd symptoms which make them worry they might be developing motor neuron disease. So anything early on that seems odd that's coming and going, it can be appropriate to include it. You don't necessarily, you take a history at that point.
Yeah.
But there's nothing absolute. It's just a feeling that something's odd or they keep coming back. And
I guess Jack's point about high risk activities in high risk areas would be as well as obviously the rash, any instance of rash, but that would be a good indicator for yourself that, you know, that would be maybe something that triggers suspicion.
And the issue of maybe psychiatric or psychological symptoms developing after the age of 40. You're not assuming things that somebody's got psychosomatic illness at that age. It doesn't tend to, you know, that's not a typical situation.
But nonetheless, I have more patients who never left their kitchen. You know, a lady from Belfast whose dog brought the tick home, and she ended up in the psychiatric hospital for 6 months before anybody thought about Lyme disease. And, you know, functional till the age of 50, working a professional woman, ended up in the psychiatric hospital with a tick bite from a dog that brought it home to a house in Belfast. So the history is important, but, you know, it's not always that clear cut. So I just think, changes in people's something different. And a person who previously, you know, I don't like to go to doctors. Most people don't like to go to doctors. I avoid doctors, you know, as much as possible. I shouldn't say that, but the point is most of my patients never went to doctors in their life. And all of a sudden here they are going to the doctors 10 times. And all of a sudden they've been perfectly normal, calm, collect. And here they are totally angry, rage, out of control, anxiety disorders, depression, psychosis. Whoa, there's something not right here. You know, there's something we're missing. So I think multi-system disease, migratory arthritis, changes in you know, a person's, you know, kind of usual manifestations, you know, rather than saying to the CEO of a company who's a multimillionaire who's doing great, or a guy who owns horses who's, you know, who got a tick bite and got neuroborreliosis, rather than saying, oh, he's just seeking attention because he wants to see doctors, you know, rather than making millions of euros, you know, we have to kind of, you know, look at the writing on the wall. If there's something different, there's something missing, you need to continue to work with the patients, you know, accept the fact that they're not malingering, they're not making it up, and you know, think of these infections as being a trigger for their symptoms.
The other thing I'd say there is, remember that on that chart I showed, there was a high risk in primary school children. They can't necessarily, they're not going to describe what's going on. Maybe they're just, I don't know if Gareth's got any thoughts on this, but there may be the parents come in just saying they're fatigued. They don't want to play anymore. They seem unhappy. They're crying all the time. And I've come across parents being told that, you know, teacher just telling them their child's stressed or depressed, and they're saying, well, no, they're not. They're just not wanting to play. They're not well. And that normally triggers us to be concerned anyway. But again, thinking about Lyme disease in children who cannot really describe what's going on. But there may have been a tick bite that mum's forgotten to mention or didn't notice.
I mean, if I can come in, I think that the crucial thing is the history, always going back to really understanding the potential for exposure and really putting that in context. And you're right, Anne, that obviously younger children are going to, you know, quite a bit of pediatric practice is fairly veterinary in some senses, that you're really trying to get clues based on observing behavior in children. And if it's changed from what it was before, we should be listening to the parents, listening to the caregivers, and giving them credit for knowing their child better than we will as health professionals, and investigating the child accordingly.
Yeah, thank you for that. That's really helpful. Now, let me look and see if I have any more questions. I think, yes. Do you ever have acute cases of Lyme disease presenting with neurological symptoms only and no others? No other symptoms, just purely neurological symptoms? Or
Neurological.
Yeah.
Certainly, I've seen cases. The case that Jack described in the young man who came from Scotland, his was a very acute, very severe neurological symptoms that have continued. There was the fatigue, but he wasn't so aware of that. He was at that time, it was just the very, very severe neurological symptoms. I've seen that in another patient who started with shooting pains, fasciculation, tremors. GP actually got the positive test, but while she was wondering or waiting for an answer back from infectious diseases on what the best option was, the patient had a massive deterioration, became severely ataxic, and was admitted and had a positive lumbar puncture, was started on treatment. But whether she made a full recovery, I'm not sure. So yes, I've seen neurological symptoms as the only apparent presenting symptom.
Yeah.
In my experience, I tend to see people years and years down the way. So I see very, very, after they've gone to 10 different specialists, you know, who have examined 10 different organ systems and never connected the dots. So this is a challenge. We need to connect the dots.
Okay, thank you for that. I have another question here is about, Jack mentioned about personalising the therapy, which is fair enough. And I think, Anne, you had said that you would, and the NICE guidelines allow for a second course of antibiotics if the patient fails to respond after the first course. The question here is it the same antibiotic or same, or would you choose something different? I guess that one's well, or Anne in particular.
The NICE guideline says change.
Yeah.
It's difficult. So if you were definitely responding really well to one specific one, then I might be less keen to change. And we know that doxycycline would maybe cover more co-infections than amoxicillin. So if I was already on doxy, I don't think I'd want to go to amoxicillin. If nothing was happening, I'd certainly probably change. But that's just what the guideline says, but I'm not sure what it's based on. Right. I don't know what Jack thinks.
Right.
The other option is to add in two.
No, I mean, there's no good evidence, you know, this is just, I think guidelines are sometimes based on consensus, sometimes based on pressure, you know, that people say. So I think the UK guidelines say 2 weeks of doxycycline, end of story. Stop the 3 weeks, but I'm saying, but they've changed. They're now 3 weeks, but I'm saying but a lot of the Irish kind of go by guidelines from 2008, 2 weeks of doxycycline, and that's the end of it. So I think if you respond to doxycycline and then you relapse after 3 weeks of doxycycline, it would make sense, like Anne said, to continue with the doxycycline because it's covering not just Lyme, but it's covering a lot of the co-infections. The NICE guidelines have expanded so that they say after 3 weeks of doxycycline, you have the option to go with 3 weeks of high dose amoxicillin, a gram TDS. But my experience is that if you get better and you stop antibiotics and you get worse, that means the antibiotics were working. So that just, I mean, that antibiotics work against bacteria, I think I was taught in infectious diseases. And if you stop the antibiotics and you get worse, that means I do this with cellulitis, I do this with osteomyelitis, I do this with meningitis. If patients deteriorate, I restart the treatment that worked. So I just think we should, guidelines are guidelines. You know, so I just think we have to use antimicrobial stewardship. We have to be careful, but we have to treat the patients and we have to treat what we see in front of us. We need to take the hints from the history. We need to take the hints from our patients and the guidance. And like I said, you know, we worry about drug resistant, antimicrobial stewardship, all this kind of stuff. I say people in India, 2.5 million people every year take 4 antibiotics for 1 year for their tuberculosis. Are they worried about antimicrobial stewardship? Are they worried about gut microflora? They're just concerned about survival. And I think, you know, untreated tuberculosis kills you. Untreated Lyme disease kills you slowly. So I just think it's a balancing act. We shouldn't use antibiotics unnecessarily. But if the antibiotics are working, we should use our clinical judgment.
Can I, something not specifically about the antibiotics, but Zara just mentioned last week, Dr. Neil Spector, who had undiagnosed Lyme carditis for many years. He was an eminent oncologist and research oncologist. And sadly, he died last year, very young, still, I think in his 50s. But his feeling was that Lyme disease research or management is where breast cancer was 40 years ago. And that's pretty shocking. 40 years ago, if someone had said you can't cure breast cancer and nobody's allowed to try, a lot more people would have died by now. We're in this situation, we're told we can't try other treatments and nobody will open clinics and nobody will do the research. It's become so stigmatized that patients are really suffering. And there are no NHS clinics, and no matter how much the patient groups have pushed to try and get someone to do that. There was one for a very short time, but there was no funding available and it was stopped again. But it was very, very popular when it was there. So somehow we have to help patients. And if we can only in primary care at least get the early cases, we won't be getting all this chronic symptoms, persistent illness.